All right. Hi, everyone. Thanks for being here and joining us today. I'm really excited about this opportunity to have this discussion with you and collaborate with Dr. Sockalingam is always a privilege for me. This is an interesting one because for our community that we have, the connection between obesity and mental health is something that definitely comes up. We get lots of questions about this, and it's definitely an important topic. So I'm glad we can kind of combine two of Dr. Socklingham's 17 different hats that he wears on a professional basis. So we'll hopefully spark some good discussion today. And like what was mentioned, we're going to have two other webinar sessions on this topic to kind of build off of it. So hopefully we can um, continue the discussion going forward. Before we get going, though, I did want to share two important resources. So one is the clinical practice guidelines. So these were published in 2020. And clinical practice guidelines tend to be tools and resources that are more focused on for health professionals. They're designed for health professionals to kind of guide their practice, um, which is important, but they can also be a tool for people living with obesity or patients themselves. Um, to inform themselves and kind of get them able to advocate for themselves, especially in a space like this that we're talking about with obesity. It's a space that's rapidly evolving. So these guidelines are an important tool. They kind of outline the evidence-based information and practices that should be included in obesity management. So a really important resource that can be found on our website. There's a very good summary article and lots of resources that are connected to it. We also have lots of education available that's based on the clinical practice guidelines. And then just another resource that I wanted to give a shout out here. OC Connect is our online kind of peer support community. So this is for people living with obesity, designed by people living with obesity. It's a private, closed, moderated peer support community where we can share some of that evidence-based information. We can interact with each other in a safe space and ask questions and kind of share all that sort of information that's in there. So another resource that's available. If you're interested in joining us, you can check that out. So with that, I will pass it off to Dr. Socklingham.
Thank you, Ian. And just want to say, delight to be co-presenting this with you, Ian. Again, I may have multiple roles, but you have multiple expertise and lenses, and both your expertise in the field and your lived experience, I'm hoping will enrich our discussion. I always say when I present with Ian, he's the main attraction, and I'm the opening act. So we'll do this together. And our outline for today, where we will talk about obesity. And I just want people who are in attendance, some of you might be part of the Obesity Canada network, some of the CAMH, and some who are just being introduced to both. So maybe some level setting on where obesity is at in terms of a definition, because a lot has happened over the last decade. We'll talk about the relationship between obesity and mental health, and hope that you'll be able to see that by the end of this presentation. We'll talk briefly about weight stigma and bias, although we have a third session that will go into a lot more detail related to this item. And then how can people living with obesity and mental health conditions be supported? And we'll do introductory, but I know Dr. Mahavir Agarwal is going to also do a session in the second webinar that will dive into this a little further. All right. So as we move to the next slide, I'm going to talk about the Canadian statistics. You probably know the stats for mental health conditions, like 1 in 5 Canadians live with a mental health condition, 1 in 2 by age 40 have had a mental health condition. 1 in 4 adults are also living with obesity. So you can think about how common both conditions are, that it's no surprise that we see an intersection between the two. And we're going to dive into some of the reasons why and the complexity related to that. Now, obesity is really important as a public health crisis because we estimate that 1 in 10 premature deaths amongst Canadian adults is related to obesity. And we also know that the prevalence of obesity has increased over the last 3 decades. And one of the points which you will see over and over, which Ian and I will go into, is obesity is considered a chronic disease. We have recognized this by our major medical associations. We have updated definitions, which we're going to share. But obesity is a chronic disease. It is not a behavior, and it is not attributable to someone's willpower or lifestyle. It is a medical illness. And so we'll come back to that. As we go into the next slide, we'll talk a bit more about how we define obesity. And you'll see this come up again. So obesity is a chronic disease, and we define it by excess adipose or fat tissue in the body that impairs health and well-being. And it's important that impairment piece is critical to this. Now, you're going to say, many of you, that if you've seen a healthcare provider or looked at ways people classify or measure obesity, something called the body mass index is one, or BMI, is probably the one that's most commonly used, right? It's calculated by your height and your weight. And it has origins actually not for patient care use. It actually came from insurance or actuarial data that over time, it's several hundred years old, but more recently in like 1960s and 70s was adopted as BMI to measure risk of death for insurance purposes. However, because it was so easy to calculate and because we had some population data, people ended up using this as the measure for obesity. And so we have cutoffs for obesity, which still are used. And when we talk about treatments and medication treatments or surgical treatments, these are the criteria that have historically been used and are being used, but are starting to be modified. And we'll talk a bit more about that. But you can see that being classified as living with obesity by BMI is 30 or more. And so we have different classes of severity. But I will just say that the American Medical Association just came out last year with a report that criticized the use of BMI as the sole or only measure for screening for measuring obesity, because it came from this insurance database, because it came from a database that was predominantly men and who are white males. And so the diversity and inclusion of individuals who are living with different body types, different cultures, were not considered in this. And so this is why BMI is still used as a screening tool, but is not the be all and end all as a measure for obesity. We go to the next slides here. So I just talked about obesity is defined as a body mass index of 30 or more, but that was how we would have classified obesity, 2 decades ago. Now, and this is reflected in our clinical practice guidelines, is obesity is a complex chronic disease in which abnormal or excess body fat, adiposity impairs health and increases the risk of long-term physical health complications or medical complications as a whole, and reduces lifespan. And this was, a deliberate change in the literature, but also in our guidelines, calling for this shift, and also moving away from what you might hear, unfortunately, still being perpetuated or communicated in healthcare settings, is that people, when you think about obesity as a BMI measure, it's quite natural for people to say, the treatment is eating less and moving more. And we know that it's much more complex than that, and we'll talk a bit more about that. But this is really a patient-centric model that's focused on the impact of excess fat on health, medical complications, and someone's quality of life. And so, again, rather than looking at weight alone, we're looking at their overall health experience. All right, with that, I'll hand it back to Ian.
Yeah, thanks for that. So this slide, I just wanted to share. This is a group of 5 principles of obesity management that were agreed upon by a group of international groups that are specializing in this space. So there's just five basic principles that kind of give us a baseline of our understanding of obesity and how to kind of move forward. It kind of gives us that foundation. So, like was just mentioned, that obesity is a complex chronic disease, um, which there's lots of information and data about that, and from someone who's experienced this, like going through and living with obesity for a long period of time, it was a really big shift for me to kind of change that mindset that this is a chronic disease and it's not something that is entirely my fault. I'm not a failure in trying to manage this disease, and there's things that are a little bit outside of my control or a little bit more complicated than just my behavioral stuff with the diet and exercise that goes into this. And so that was an important kind of realization for me, and it really helped me along the way. The second one is that obesity is driven by powerful underlying biology and not by choice. And so this kind of gets to that point that there is more going on. We have strong genetic and biological drivers of obesity that our bodies can resist weight loss and those sorts of things and fight against that. So if anyone out there has, like myself, has gone through and, gone on a restrictive diet and lost 50 pounds, or something along those lines, our bodies can actually resist that and kind of fight against it and kind of drive up hunger cues and different things like that. So there is some biology there that is outside of our conscious control and individual control that we need to take into consideration. We also know and understand that there are many health effects of excess weight that can start early. So it's important that we have early identification and intervention and recognizing this early on before it gets too late, before that disease progression gets too far along. We also know that obesity is treatable, so this is kind of pointing to like the things that are in our clinical practice guidelines. There are evidence-based treatments that are out there. They are available, and we do have some idea of what we should be doing when it comes to obesity management. It is a very rapidly evolving space, so it is something that is changing pretty regularly, and so that's why we update our clinical practice guidelines as that new information comes along. And then the last one is that weight bias and stigma and discrimination are all prevalent in our society, and they are very harmful. So we know that shame and blame does not work. It's harmful to people, and we need to kind of change the narrative and shift how we're talking about weight and obesity and these sorts of things. So those are kind of the five basic principles of obesity management that we all agree on. Right. Pass that back to Sanjeev.
Thank you. So building on what Ian's talked about, and in that definition that we both shared, we've talked about the medical complications of obesity or the health complications of obesity. So there's obesity, but we know that for many people living with obesity, they have other conditions. And sometimes, and we'll talk about mental health specifically, that there's a chicken and egg, like what came first, and we can see that there are different pathways or journeys for patients, that sometimes there are mental health conditions that lead to obesity and vice versa. But there, as you can see, obesity impacts so many parts of our health and organ systems. And so whether it is, obesity being associated with higher rates of sleep apnea, obstructive sleep apnea, increased heart attacks or cardiovascular risk and stroke, reflux, kidney failure, skin rashes, infertility from polycystic ovarian syndrome, for example, increased risk of various cancers as well. All of these are important that underscore the need that in order to treat many of these conditions, we also need to think about treating obesity. And in fact, sometimes treating obesity can prevent some of these conditions from developing. And you notice depression is there as well, and we'll come back to that in the next few slides. I want to just say, mental health is clearly embedded in obesity, not only as a complication, but also how we think about what we call kind of grading the severity and informing our treatments for obesity. So I mentioned that BMI is a screening tool, and so you might go to see someone in a healthcare setting and get a BMI measurement, and there might be someone who has a body mass index of 31, which would be classified just by BMI as being classified as living with obesity. However, this is from the Edmonton Obesity Staging System, which looks at, we also need to consider other factors, right? So are there other health factors? So someone with a body mass index of 31 has no other health conditions, their mental health and well-being is pretty good, and they're functioning. They may be working, have a great social life, doing well. Compare that person to someone with a body mass index of 31 who also has osteoarthritis or arthritis, sleep apnea, and also has now developed depression and anxiety, has kind of not been able to work, and is really feeling more isolated as a result of all these health conditions and excess weight. And so if you look at that, those two individuals, I think it's pretty clear that one is experiencing a lot more medical, mental, and functional impairment, and one that is not. And so we would say that person, the first person, might be more stage 0, and the other one might be much more severe along the stage 3, 4, depending on some of the further assessments. So I think it's helpful for us to use body mass index as a screener, but really delve into the impact on people, because that informs who needs some more urgent treatment and who can we work with other treatment interventions or preventative interventions to help some of these other co-occurring conditions. All right, now we talk about obesity and mental health. We've kind of planted the seed that they're so closely linked. If you look at studies that have people who are seeking treatments, and one treatment is metabolic and bariatric surgery, but it's one of our 3 pillars, which we're going to talk about half or 2/3 of people who present to those clinics have a lifetime history of having a formal psychiatric illness. Most of that is either depression, could be anxiety, which is around 15 to 20%, and binge eating disorder being one of the most common eating disorders that are associated with obesity, and I'll talk a bit more about that. We also know that people who have developed mental illness first, depression, bipolar disorder, schizophrenia, they also have high rates of obesity. So depression's 20 to 50%, bipolar disorder 25 to 60, and higher rates in people who live with psychotic illness. So you can see there's a real overlap happening, and it's important for us to include mental health in obesity treatment and vice versa. And I'll just say, why is it important in addition to them both co-occurring? They influence each other. If we look at people living with bipolar disorder, they have twice the rates of obesity, and women with bipolar disorder have higher rates of obesity when you look at large studies of thousands and thousands of patients. Obesity also has a negative effect on the treatment and response to treatment for someone living with bipolar disorder. So people living with both obesity and bipolar disorder might have higher rates of suicidality or suicide attempts, more severe symptoms of bipolar disorder, or if they're been treated and had their condition bipolar symptoms in remission, they might get relapse sooner. And also people living with bipolar disorder who are given certain treatments, like medication treatments, may be less likely to respond if they're living with obesity as well. And so treating obesity is really important for us in terms of trying to improve symptoms, quality of life, and outcomes. And then I see there's some questions coming up about binge eating disorder, and we'll talk about that at the end. But I just will say there is a relationship between binge eating disorder, which is a clinical diagnosis of having loss of control over eating and eating a larger amount of food over a certain period of time. And this is associated with other symptoms, but also functional impairment and distress. And we see that although people can have binge eating disorder and not have obesity, people who are living with binge eating disorder have higher rates of BMI, and people who are living with obesity with higher BMI, and I know BMI is just said as a screening tool, but for the purpose of this, people with higher BMIs are more likely to have higher rates of binge eating disorder than not. And so again, if you look at these rates, these are pretty high. The lifetime prevalence of binge eating disorders, 3.5% in women and 2% amongst men, and that's independent of living with obesity, but living with obesity increases the rates as well. All right, and so I want to talk about, so we talked about binge eating disorder, but there is a continuum of disordered eating in obesity. So all of us have a drive to eat that is part of our natural kind of circuitry and survival, what we call our homeostasis. So our brain tells us to eat at certain times in hunger cues. There are times where we might overeat. There are times where we might have loss of control over eating, and that might happen intermittently. There are some people who develop binge eating disorder, and then some people who have even stronger binge eating disorder that goes on to the point of compulsive eating. It's a term called food addiction. Food addiction, by the way, is not a diagnosis as per DSM-5, but a concept that people have noted. But it really is about a strong, more compulsive type of disordered eating. And going across this continuum can lead to increased risk of obesity. It's linked to changes in the brain. And I'm going to take a moment here just to talk about what we mean by brain. So as a psychiatrist, one of the most fascinating things and important things that has evolved in our understanding of obesity is the link between obesity and the brain, right? People think of obesity as a body issue, but it's a brain issue. And so I want you to kind of note that we have different parts of our brain that have different roles in eating regulation and weight regulation. So, for example, we have a reward pathway, which many of you may be aware of, that's also kind of highly relevant to substance use and drives to use substances. But the reward pathway, which is in the mesolimbic system, is important for us because it is the pairing of kind of the want to eat and the pleasure with eating. And that coupling that happens is important for survival. So we have this circuitry that's there that is part of this reward pathway, and is important for us because at times where food was scarce, you can think, in our cave days, so to speak, that people were hunting and gathering. We needed people to couple and have these cues to go seek food, get food, and be motivated to hunt so that they could eat and have enough food around them. Now, there is a relationship between this kind of pleasured eating and homeostasis and how our body reacts and our metabolism, but I'll save that alone. If you think about the reward pathway, in our historical sense, it doesn't serve us well in our current sense where food is plentiful. If I look out my window right now, there are many places to get food very quickly right now, and often high calorically dense food, and maybe not the food that we would consider as having a good nutrition. And as a result of that, those kind of cues and that food and that what's availability is problematic. And Ian talked about genetic drives. There's genetic factors. There's other factors as well, other co-occurring conditions that can alter this reward circuitry. And so this drives our increased consumption of food and that reward activation. And what tries to stop some of this is our prefrontal cortex, which is associated with regulating and kind of the thought process. It's how behavioral interventions or cognitive behavioral interventions actually work, whether it's for depression, CBT, for example, or cognitive behavioral therapy works on that executive functioning or prefrontal cortex. And similarly, that happens in obesity. It causes us to pause or stop and regulate our eating. And so we have this circuitry, It was good for us when food was scarce. It is problematic in a food plentiful environment. And one of the reasons why it shifts us from thinking about, oh, this is all about willpower and eating less and moving more. There is a biology that drives people, and there are factors that increase that biological drive in our brain as well. So we'll go to our next slide. We've talked about the relationship between obesity and mental illness. I will say that there are many factors that overlap and might be influencing the interplay between obesity and mental illness. So there are biological factors, both obesity and mood disorders, for example, have chronic inflammation states that may be affecting the brain. We have parts of our brain called the hypothalamus, the pituitary gland, and our adrenal gland, and they're all interconnected. And there are definitely alterations in their relationship and cortisol levels. Our gut microbiota, so that's what's in our gut, the bacteria in our gut that are healthy, they're altered. And there are studies that are looking at ways to alter that, both in mood disorders, but also in obesity. And there are shared genetic variations. There's, in fact, some shared genes that are risk factors for both ADHD and for obesity that have been identified. There are psychological factors, and Ian will talk about the impact of stigma and discrimination. We know that psychological trauma can also increase the risk of developing obesity, but also obviously mental health conditions. Sleep deprivation is a huge risk factor for developing obesity, and sleep is one of the vital signs for mental health. And when you have disrupted sleep, it often is either a sign of other mental health conditions or a risk factor. And you can imagine people living with depression may have problems with physical activity. And there are many social factors. Obviously, if people are unable to work due to mental illness or obesity, it may limit their ability to access healthier foods. It also, we know people living with both often have limited access to healthcare or primary care or preventative care in those circumstances. We'll go to the next slide here, and I'll hand it over to you.
We mentioned briefly the topic of weight bias and stigma, and this is something that we will dig into a bit deeper in the third webinar that we're going to do. But it is important to understand and recognize the impact of weight bias and stigma, and it is something that is prevalent in our society. So these negative attitudes and beliefs about people living with obesity or obesity treatments and those sorts of things. It could be even the environments and how they're set up for people living in larger bodies, and those sorts of things can all play a role in this. And that can have a big impact on how people experience, whether it's healthcare or even just being out in public and how they experience the world. So can have a big role in this equation that we're talking about. And this one, I just wanted to highlight the impact with a large percentage of people with obesity experiencing weight bias and stigma in healthcare. And from our community, this is something that I hear about on a regular basis. We get lots of questions about people and their experience that they've had with physicians or other healthcare professionals in the healthcare space. So it is a really big concern from our community and something that that we need to address, we need to do better at. And I think that's something we can do. A lot of it is stemming from misconceptions about what obesity is and our understanding of it, which we've said is evolving, but we still have lots of work to do. And so this is just another one showing the prevalence of weight bias. And so looking at the two definitions at the top there, weight bias being the negative attitudes and views about obesity and about people with obesity. And then stigma is kind of referring to the social stereotypes and misconceptions about obesity. And as the data shows here, this is looking at particularly women. This was done in the US, but pretty high rates of people experiencing weight bias and stigma in healthcare from their physicians and doctors. So definitely something that we can do better at. And a lot of that comes down to communication and our understanding of the disease. when it comes to our community and some of the things that I get questions about or people raise, the stigma and bias that people experience could be from external sources. It could be from the environment. So, like walking into a hospital or a health setting, and the environment's not set up, it doesn't have chairs or things that are, it's not accommodating or welcoming to those people. It could be experiences directly from other people and things that are said or how they are treated in those spaces. But it could also be internalized bias and stigma. So we could have that internalized stigma, and um, that can impact how we access and interact in healthcare spaces. So if we're going in with that internalized bias, we're already feeling pretty bad about ourselves, and we've got those negative feelings ourselves. We maybe don't feel like we deserve the care and treatment and the respect that we should be experiencing there. That can impact how we interact with our doctors and can change that whole dynamic. So we also have to recognize that we have that internalized bias as well. And when it comes to bias and stigma and the mental health complications, there are a lot of things that a lot of these complications that are related to it. So things like depression, anxiety, poor body image, self-esteem, suicidality, disordered eating, and substance use are all things that are connected to that weight bias and stigma. So if we can address weight bias and stigma and reduce some of that and make it a little bit better, maybe even regardless of weight loss or those sorts of things, we can probably have a positive impact on people and their outcomes. So that's definitely something we need to do better at. So I'll pass it back to Sanjeev here.
Thank you. So we'll transition now to what to do when someone might, as you know, or if you are experiencing living with obesity and mental illness, what are the potential supports or approaches that might be helpful? And this comes from our guidelines, but also from the experiences of people living with these conditions. So if we go here, this is one diagram, and I know it's a flow diagram, so it might be a little complicated, but I just want you to focus on the title, that this is the patient journey in obesity management. And so we have 5 steps in this model. And one is to ask permission if it's all right to speak to an individual. So as a healthcare provider, and someone's coming in, it's to ask if their permission, if they would be all right if we discuss their weight. And if for some people that's not their focus, and that is completely fine, and that's where we're at. And others, that might be the reason they're seeking care and that they are experiencing difficulties. And I think number 2 is the most important, because you've seen so many factors and so many variables that might influence someone's risk or the development of obesity and also mental health complications. So it's important to assess their story. So, that might be understanding, although we might use weight as a starting point, there are many factors that impacting someone's health as it relates to weight, but other disease conditions, and using that staging system might be helpful. And then we advise on management, and there are 3 pillars which we'll talk about: treatment, the psychological, there are medications for obesity treatment, and metabolic and bariatric surgery. And these are all used to support changes in nutrition and physical activity, and we'll talk a bit more about that. And then we make sure we're agreeing on treatment goals together with our patients, and then we assist with any drivers and barriers through longitudinal follow-up. So that's really the pathway for obesity management. If we go to ask, in addition to kind of asking a person if they want to discuss their weight or their desire to seek obesity treatment, the most important thing is, even before we have a conversation, is the spaces in which we are having these conversations or caring for individuals living with obesity. Many of the spaces where we work are not equipped to have inclusive and accessible environments. So that could be the chairs, if they're in hospitals and need gowns, the scales people use. And again, there are some places where the scales are in public settings, which can really reinforce kind of negative feelings and experiences for people living with obesity. Blood pressure cuffs, and there are ones that are uh, um, larger sizes that can help individuals in accurate measurement, but even the restrooms and doorways, and many others. And so in the guidelines, there's actually checklists and some guides that can help people who are working in healthcare settings, but other settings as well, to create more inclusive environments for people living with obesity. If we go to the next slide, the assessing for obesity in drivers, I mentioned mental health, and I've kind of highlighted that in this slide, but there are other physical health complications. There's metabolic complications like diabetes, fatty liver, and then there are monetary or social factors, and that's kind of employment, education. All of these are part of that patient journey, and they also are part of the factors that we need to think about in support our patients if we want to give them comprehensive treatment for obesity care, and that also relates to their mental health care as well. So just to highlight, these are the areas that we tend to focus on. If we go to treatment approaches, as I mentioned, we have psychological interventions, and a lot of that you can see that is a key pillar, sometimes difficult to access in our healthcare system, but a key pillar to treatment. That includes behavioral modification, focusing on sleep time, stress reduction. And there are treatments like cognitive behavioral therapy or acceptance commitment therapy that are really have been shown to have some benefit in treatment, especially in combination with many of the other treatments that I talk about here. There are new pharmacological treatments that are emerging and being studied through research for people living with obesity that have also showed significant health benefits beyond just weight reduction, like on cardiovascular risk, fatty liver, sleep apnea, pain related to osteoarthritis. So important for us to note that. And then we have metabolic and bariatric surgery, and there are two types that are usually done, like sleeve gastrectomy or Roux-en-Y, and these have evolved over time. They're much safer now, and are accessible through provincial programs in most provinces as well. I say accessible, but there are some differences in wait times from province to province. And this is, again, to support nutrition changes and nutrition management, which is part of our goals, and physical activity. And I talk about eat less, move more is not a treatment for obesity because of the complexity of obesity. But we're not saying that physical activity is not good. It's good for health. It's good for mental health. And same with nutrition as well. And so we want to support this for our patients who are living with obesity and living with obesity and mental health conditions. All right. And this is the last slide because we're going to talk about this in the next. Dr. Agarwal will probably talk a bit more about this, but for people who are living with both obesity and mental illness, important to assess all causes, not just focusing on mental illness, but also the physical health complications, some of the social factors as well, and work on a collaborative plan with your healthcare provider. So that's that agreement, like understanding it together and getting to agreement. It's important to treat both mental illness and obesity together. You don't have to wait, and that really having an integrated plan is important. Someone might have this question, but there are many medications that I prescribe as a psychiatrist that could have effects on weight and the risk of developing obesity. And whenever possible, important to review, are there better choices that have a lower risk that are possible and that are effective? In some cases that's possible, in some cases it's not. And then you need to be able to have those discussions with a physician or a nurse practitioner or other healthcare provider, and to explore what's available and accessible, whether you're in Ontario or another province. And that's those three pillars of treatment, and cost and coverage are a significant factor. And I know Ian always is trying to work across our networks to increase access through advocacy for these treatments. And so this is an example in Ontario. I think many of you are attending today are probably from Ontario. There is the Ontario Bariatric Network. Healthcare providers, any healthcare provider can, or physician can refer into or nurse practitioner can refer into this program. There's a surgical and medical treatment program, and it's covered by OHIP. And part of this is these are team-based care. They're not solely physicians. They include mental health provider, whether a social worker, psychologist, or psychiatrist, or all of the above, dietitians, nurses or nurse practitioners, and surgeons and other medical specialists as well. And so it's important to know that that's out there. There are some wait times and access challenges, but it's generally the goal is to get people into these treatments after thoughtful assessment and engagement within 9 to 12 months is the goal and the benchmark in Ontario. So I will end there, that there's a strong relationship between mental health and obesity. Obesity can have a negative impact on mental health conditions. There are many factors for us to think about and assess, and important to have that comprehensive assessment. We'll talk more in subsequent about weight bias and stigma and the impact on seeking obesity treatment, but you heard a little bit from what Ian introduced. And there are evidence-based treatments available for people living with obesity, and that's really important in terms of the impact on mental health and mental illness. And we'll stop there to have some questions. Thank you.
Thank you so much. It was a great presentation and lots of great information. We have some questions. So first question is around, and I know you've addressed it a bit, but there's a lot of questions talking about mental health and psychiatric medications and their impact on weight. And I guess maybe if you have any further comments around, how folks should discuss that with their doctors, and maybe some strategies. And yes, and I recognize that we have a whole webinar on this, so
I'll try. I can answer it really briefly, just and make sure. And Dr. Agarwal would be a great person for and who's going to present in the next webinar, who'll go into a lot more detail in this. So just to say that for sure there is a link. I see some of the questions that it is a vicious cycle too, because people might be suffering from depression, other mood disorders, psychosis, and are on medications that can increase their weight, but it seems the medications work, but then they experience weight gain or metabolic abnormalities like diabetes and high cholesterol and other things. And of course, that can be devastating for an individual, which can further have that vicious cycle and impact mood. And so wherever possible, we try to choose medications with the lowest risk. We promote a multi-component program that is kind of behavioral, physical activity, etc. Those have some benefit, especially for weight maintenance, so that people don't gain weight. And then there are medications that sometimes are tried, and some of them are cheaper, and some of them are more uncovered, and some are not, but are available that have shown benefit to help prevent further weight gain or weight loss if people have experienced it from their medications. And Dr. Agarwal can talk a bit more about that in the next session.
great. Another question is about Ozempic and related medications. And does taking Ozempic reduce binge eating or that loss of control with eating?
Yeah. So maybe I'll let Ian. Why don't you start with just like the experiences that you've heard and some of that, and I can talk a bit about some of the biology briefly.
Sure. So as someone who has obesity, has gone through obesity management myself, I currently take one of the medications that is approved, and also have been diagnosed with binge eating disorder. So the medications like Ozempic are not indicated for binge eating disorder specifically, but I can tell you from my perspective, like my experience with it is the medications have given me a little bit more control. So I've got a reduced food noise. I'm not always thinking about food, and I don't have that like compulsive drive that was a big, fuel for my binge eating that I was doing. So it's helped, but it's not directly indicated specifically for binge eating disorder.
And that is the kind of evidence that, we think through the changes in hunger, the food noise, that there may be some indirect effects when you look at some of the studies and the clinical trials that for the approval of these medications, they do reduce disordered eating, but they haven't been studied for binge eating disorder, which is, as I showed you on that spectrum, a very distinct kind of type of disordered eating, but it could help with people's symptoms as well. But it is not indicated and tested in a clinical trial.
Great, thank you. Um, Another question, what percentage of obesity is not treatable? Are there cases where,
Yeah, I think we haven't had many treatment options available for people um, to come up with robust factors in the real world, because there are in clinical trials a proportion of people who don't respond to medications or psychological treatments or metabolic and bariatric surgery. Um, so, for example, in surgical treatments, it depends what you define as not respond, right? Uh, if someone has had metabolic and bariatric surgery, usually by year one, they will lose 30%, give or take 5% of their total weight, but will regain a little bit of weight beyond that first year, which we call the honeymoon year, and will, on average, have somewhere around like a 20% to 25 percent total weight loss long term, over long term, meaning a decade. But there are people in different trajectories, and we did a study. There are like 5 trajectories that we found for weight and for quality of life, and it really depends on the individual. And so I can't say I have a proportion of people because most of the definitions have focused on weight loss, and we just finished talking about that weight loss is not the only kind of treatment outcome that we want to focus on. And so it's hard to say, but I will say it is individualized. But the good news is we have more treatments available for people across the pillars of obesity care. I don't know, Ian, if you wanted to expand on that as well.
Mhm.
No, I think you answered that fairly well. I don't know if I have much to add to add into that. There was a comment in here that I picked up on from Taylor about talking about the divide in obesity in the obesity space about using the different terminology and like in especially in healthcare professionals, should they be focusing on emphasizing that medical management side of things and defining it as a chronic disease, or should we be, there's some certain portion of folks that are suggesting that that could be stigmatizing and frames it in a harmful way. And so they encourage avoiding terms like healthy weight and normal weight. I would actually say that I would even, from Obesity Canada standpoint and those sorts of things, the healthy weight, normal weight stuff is not ideal terminology either. I generally avoid using those terms as well because we know that BMI and those sorts of things are not great classifications or identifications of an individual's health. So I think there's a lot of overlap in those two spaces. The way I approach this is that, we have pretty solid evidence that obesity is a chronic disease, and there is international consensus among a lot of among the experts that it is a chronic disease in and of itself. So that's the way we approach it. The kind of pushback on the stigmatizing kind of side of, not using obesity and the body positivity side of things is rooted in the fact that, historically that stuff wasn't used appropriately. We weren't looking at obesity as a chronic disease. We weren't looking, it was all about weight and weight loss, and it's kind of fueled that eat less, move more narrative. And so we're trying to move away from that, but it doesn't mean that obesity is not a chronic disease and we shouldn't address it like one. Um, so I don't know if you have anything to add into that. It's definitely a conversation that comes up pretty much every time we talk about this.
Yeah, I think you've really touched on it, Ian. It's taking a more comprehensive approach really addresses some of the complex nuances of this in a more fulsome way. And we still are working, battling against this. I'll just say as we're getting close to kind of nearing the end here, like, for me, as a psychiatrist, Ian's heard me talk about this as well. Like, it's really eye-opening to me to see how mental illness and mental health has had to undergo and battle stigma over the last you know several decades, and we are made some movement in that area and work where people recognize depression not as someone's willpower or inability to do something because of will, that it's an actual medical condition. But it's required a lot of work. And I would say obesity as a chronic disease is undergoing the same stigma in that way, in that people have had to really change how they think about obesity and move away from this being someone's willpower or something behavioral that they can just control and should be just doing better, right? We wouldn't say that to someone with depression right now, like just feel better, like you should be feeling better. Like someone with obesity, oh, you should just control what you eat and exercise more, and you'll be better, right? And so we have a lot of work to do, but some important lessons learned from both that I think we can carry forward.